Yes, ma'am, we are good to go.
Good evening, everyone. We are here again with this webinar series that Fortis Memorial Research Institute has been doing for months and been learning a lot and a lot. This one is really special because May is Pediatric Brain Tumor Awareness Month, or we always say Go Grey this May. So this May, we've been planning a very special series, and we have a very special guest with us, Dr. Craig Edgar. So before introducing him, because it's really a pleasure to introduce him here. Before introducing him, I would really like to highlight the topic first, which is tackling the BRAF mutation in neuro-oncology approach and management. It's a very important topic because in and out, we've been getting BRAF mutations, BRAF fusions, and we always wonder what to go about, how long to go about, how much to worry, how much not to worry. So, being privileged to invite Dr. Craig Edgar, he's an associate professor, Department of Pediatrics, pediatric hematologist, oncologist at Health Center Dalhousie University. He has so many important publications to his name that we see his name more often again and again in our important guidelines, in our important dealings. So obviously he needs no introduction and no PowerPoint slide. And very special to have you this May. Welcome, Dr. Craig. Very welcome to this Indian platform of Indian neuro-oncology. And here we go, and the podium is all yours, sir. Welcome.
Thank you. Dr. Swati, is it okay if I share my screen for the slide? Perfect. How's that? Can you see? You guys see? Can you guys see my slides, Dr. Swati?
I'm sorry, some technical error. Yes, Dr. Craig, I can see your slides.
Okay, great. Okay, so just let me know if you guys can't hear me or if there's any problems with the audio. Thank you. So my name's Craig Urker. I'm a neuro-oncologist, and I'm in Halifax, Nova Scotia, Canada. It's wonderful to be here. Thank you so much for inviting me. We're going to be talking about BRAF mutations in neuro-oncology. So the goals of this presentation will describe the spectrum of BRAF mutations in neuro-oncology, describe the historical data and management of these tumors, and then discuss current strategies in management, and then discuss some future directions of care. So first, I thought we would start off by discussing the spectrum of BRAF mutations in pediatric neuro-oncology. So this is a publication that was in Cancer Cell. You may be familiar with it. It was by Rael and Dr. Taburi as the senior author. And basically what we can see here is that childhood low-grade gliomas with over 1,000 of these tumors that they analyzed, over 50% of them will have a BRAF mutation. And so that's quite significant. And you can see here the most common mutation for low-grade gliomas in pediatrics is the KIAA1549 BRAF fusion, followed by the BRAF V600E. And then there's also a few other more rare BRAF mutations, different kinds of fusions or different insertions. So all pediatric low-grade gliomas harbor some sort of MAP kinase pathway alteration. And again, just to sort of highlight, actually it was known back in 2008 that the duplication in the BRAF gene, later known as the BRAF KIAA1549 fusion, was the most frequent event in pediatric low-grade gliomas. So this is just showing what we just talked about, is that overall, you can see that the phosphorylated ERK, or the upregulation of the MAP kinase pathway, is universal throughout pediatric low-grade gliomas. this is normal tissue. These are the tumors there. This is a publication that my colleagues and I did here at our local hospital. We just took patients with low-grade gliomas, and we were analyzing their uh, imaging characteristics. And what we found is that with KIA1549 fusion, vast majority of these patients are in the posterior fossa, whereas in the BRAF V600E, these low-grade gliomas, when they have this mutation, are most often in the cerebral hemisphere. So very different in regards to location. So you can almost infer, although you still have to test, uh, if this is going to be a patient who has a fusion or the BRAF V600E point mutation. Uh, this slide is just showing, again, some of the differences in pathology. You can see the BRAF fusion versus the 600E. Difference in pathology. So the BRAF fusions will mostly be pilocytic astrocytoma, whereas in V600Es, you see a lot more ganglioglioma, PXAs. Also, the V600E patients are generally older. Okay, so they're generally older with a median age of 10.6 years. And as you can see, the location does vary as we just talked about. So over half in the cerebral hemispheres versus over half of the fusions in the posterior fossa. I think one area that is always important that we don't know is these low-grade gliomas in the brainstem, spinal cord, or in the optic pathway hypothalamic region. Those could go either way, and we don't really know just based off of location alone. Some people have been looking at imaging and using diffusion weighted imaging, where the V600Es may have a little bit more density to those tumors. Regarding outcomes, this is significant. So they both will achieve about 40, 45% GTR upfront, or gross total resections from initial surgery. And what we can see here is that the BRAF fusion, the progression-free survival decreases over 5 to 10 years to about 60% or so. You can see in the V600Es, historically, patients have continued to have drops in their progression-free survival. And actually, this has actually caused a drop in their overall survival. The V600Es historically have been a little bit more ominous from a survival and morbidity standpoint. Then I also just mentioned here, there's numerous other non-canonical mutations that have been found in BRAF fusions and other point mutations. So just to know that they exist. There's really not tons of data, but they do respond similarly to treatment. This is the BRAF fusion. You can see here on chromosome 7, generally BRAF and KIA1549, these genes are not too far away. And what happens is there's a fusion between these two genes, generally in the on between exons 9 to 18, with the KIA1549 exons 1 to 16. This is within the kinase domain here. So this results in an abnormal chromosome 7 and an abnormal gene that's constitutively active. And you can pick this up on fish as well. So the BRAF V600E is a specific point mutation that occurs in the kinase domain, where a valine is altered to the amino acid is altered to a glutamic acid amino acid there. And so this alters the protein, and the activity is ongoing with this mutation, just with that one small change. So from there, just wanted to talk a little bit. So when we think about low-grade gliomas, we generally think about pediatric low-grade gliomas as a tumor that will stay a low-grade glioma. However, some of you may be familiar with this manuscript that was published in 2015, again out of the Toronto group. And what they show is that they analyzed 886 patients with pediatric low-grade gliomas, and 2.9% of them developed malignant progression, or 26 patients. And the most common mutation that they were seeing transform from low grade to high grade glioma was BRAF V600E with concurrent CDKN2A deletions. These are more common in patients with pleomorphic xanthroastrocytoma, or PXA. You can also see there's some uh, co-alterations in the BRAF V600E with TP53. So if you have BRAF V600E and you have a tumor, you should consider checking these tumors for CDKN2A deletion as well, because if that's present, those tumors can be more difficult to treat and can be more resistant to therapy. And then you can also check for P53. So these are important things to sort of look for. Okay. So again, so these tumors start as low grade and then can transform in some cases to high grade. So that was pediatric low grade, and then pediatric low grade transitioning to high grade. And now I'm just going to talk to you just very briefly about childhood high grade gliomas. This was another manuscript published by the McKay Group in the UK, and so they had over 1,000 pediatric high grade gliomas that they had from various databases and biobanks, and they had 500 patients, 535 cases that were able to be tested for BRAF V600E, and 32 of those were positive. That means in pediatric high-grade gliomas, we're looking at about 6% of these patients that will be pathologically or histologically high-grade glioma. So you can see here, these are the BRAF mutations. So some of these are going to behave like low grade, but some of these are going to be PXA-like, and they're going to have the BRAF with the CDKN2A. So to just be aware of that. Other tumors that have the BRAF V600E are, CNS LCH. Otherwise, the BRAF mutations are fairly uncommon in other tumors outside of glioma. I think those are the main things. The only other thing to highlight here is that BRAF fusion is uncommon in pediatric high-grade glioma. So we generally aren't seeing a lot of BRAF fusions with high-grade. It's usually the V600E point mutation. Moving on now to populations of AYA, and so this is patients who are aged 15 to 39. This is maybe a paper that you guys haven't seen just because it was really published like just a couple weeks ago. And again, this was done by Julie Bennett with Cynthia Hawkins in the Toronto group. And basically what they did was they took all of the patients that had tumor tissue from Ontario, from several sites in Ontario, which is a province in Canada. And totally, they had 873 patients with adolescent young adult glioma aged 15 to 39. And what they found is here for BRAF mutation is that 11% of these patients had the V600E mutation. 100% of these were in the hemisphere. You can see over here, the BRAF V600E, all of these were in the hemispheric location. And then there was a small percentage, 4% of BRAF fusion. So you can see in the pediatric group, especially in the young group, you have lots of BRAF fusion in the low-grade gliomas. But as you get into the AYA, V600E becomes more common, and BRAF fusion becomes less common as you as these patients get older. And the BRAF fusion can occur more where you can see it some in the hemisphere, some in the cerebellum, um, some in the diencephalon. So again, this is looking at BRAF V600E tumors, whoops, and how they change with age. So you're going to see V600E is going to be mostly low grade as the children are younger. But there is going to be some patients that will have high grade, as young as 5 to 10 or 10 to 15. And then as you get older, more of these patients will be high grade. And you can see here just the proportion that have the CDKN2A or P53 mutations um, BRAF 600E mutation ranges from about, you know, really from like 10 to, 30%. So it's pretty significant. And again, this is just the age for the V600E tumors. So most of them in pediatrics will be low grade, but there will be a small number that will be high grade glioma. This is another study that is, I guess this information would be confidential. It was done by Adrian Levine. He's currently working on getting this information. But he collected, I think, a few hundred patients, 260 or so patients that had disseminated low-grade gliomas. So these are patients that had evidence of metastases. Every once in a while, you'll see a patient that has metastatic disease in the presence of a BRAF V600E or a BRAF fusion. And I guess that's always puzzling because we don't anticipate that. But it happens often enough that they were able to do a pretty large study with this finding. They found that, these tumors can either present with diffuse dissemination, they can have dissemination in spots, or they can later disseminate. And what they found is overall patients that have dissemination with low-grade gliomas is that their overall survival is worse, and their progression-free survival is also much worse than those that do not have dissemination. So the blue lines, these top two here are the overall survival, and then the bottom two here are the progression-free survival. And you can see the red line, the progression-free survival for the disseminated, and then the solid red line shows the line for the overall survival of the disseminated. And what I'm trying to highlight here, so this is Adrian's cohort, and our group contributed some of this data too, is that most of these patients are with BRAF mutations. Here's BRAF, BRAF, BRAF. And the majority of these are alterations with the fusion. But you can see some in red here have the V600E. So pretty widespread. There's of course other mutations in there too. But a lot of these are with the BRAF alterations that have the dissemination. And then those with diffuse low-grade gliomas, so if they have disease sort of throughout the leptomeninges, this is diffuse leptomeningeal glioneuronal tumor, and they have often will have 1p loss and 1q gains in their copy number variants. Many of these patients had treatment before their data was sent. And what we can see here is that over here on this curve, that patients who are treated with chemotherapy with dissemination of low-grade glioma versus those treated with targeted therapy, the patients that were treated with targeted therapy do better. They don't do as well as those with non-disseminated low-grade glioma on targeted therapy, but overall they do better than with chemotherapy alone. So I felt that was important to highlight. So we're just going to describe very briefly about the historical data and management of low-grade glioma. Since low-grade glioma is going to be more of what we see, um, historically, there's been several different, standards of care for low-grade gliomas. Um, this one here on the bottom was the COG study um, at or CCG 9952 back before 2000s. They were running the study to not separate by obviously BRAF mutations or even NF1, non NF1 until later. And what they found is that, essentially these two combinations, carboplatin vincristine versus another combination called CPCV, were very similar. And because of this, most people actually in the United States went to using standard treatment for low-grade gliomas with carboplatin vincristine. But overall, in Canada, we used vinblastine. This was by Alvaro La Saleta when he was here in Canada, published this work on weekly vinblastine. I'm not sure exactly what you guys use at your institution, but you can see here pretty similar outcomes, by 5 years, about 50, 60%. And overall, you can see that a lot of these curves just look very much the same. So there's been lots and lots of work and studies done, and you can delay or omit chemotherapy or radiation in the majority of these kids with chemotherapy regimens, but the outcomes were about the same for those that needed chemotherapy, usually around, 40 to 60% at 5 years. So this brings up the era of targeted management with these tumors, and this was one of the first citing publications that came out of the Pediatric Brain Tumor Consortium, led by Jason Fangasaro, who's now in Atlanta. And his this group was looking at selumetinib for patients with BRAF aberrant or NF1 type recurrent or refractory low-grade glioma. So these are patients who had already had different forms of therapy. And you can see here, they had, 51 patients here, 25 in stratum 1 and 26 in stratum 3. In the patients who were in the stratum for the BRAF um, aberrant mutation, you can see here just the response to selumetinib. And selumetinib, for those in the audience, is a MEK inhibitor. I think important to note um, there was a study done with BRAF mutant fusion low-grade gliomas that was run out of Memorial Sloan Kettering using sorafenib, and those tumors actually grew on the sorafenib, and so that was published, and so they knew that with the BRAF fusion they wanted to go further downstream, hence the MEK inhibition. That seemed to work quite well. So this is quite exciting. Canada here, where we were working with Dr. Sebastian Perrault to recruit patients with low-grade gliomas. And you can see here, these patients were refractory or progressive after treatment. And group 3 is just those with BRAF fusion. We recruited up to 42 patients. And they were using trametinib, which is a Novartis analog of selumetinib. It's another MEK inhibitor. And you can see here, this is confidential data, just the reduction in size of these tumors. So here's the group 3 patients are in yellow, and you can see a lot of different patients responding to various degrees. But of course, not everybody is responding, and we always have to be straightforward with families that this is a targeted therapy, and although we expect most patients to have some benefit, we do not see it for all patients. And so this is sort of what they're looking at for median progression-free survival with targeted therapy is about 29 months. I will say that on this study, patients were on the treatment for 18 months. So, right about here is where patients would halt therapy, and you're looking at like 70% of patients that are without progression at that time. And then when they come off therapy, a number of patients goes from 70 to about like 40. But even then, there's a high number of patients that are still without progression of their disease after they come off of trametinib. And then the same thing, I don't have the curves here for this, but there was similar finding. The selumetinib study, they were on the drug um, for 26 cycles or 24 months. This is an example from the trametinib study or the TRAMA-1 by Dr. Perot, where he's just showing this is a patient with a fusion, a BRAF fusion, a 3-year-old, and what you can see is after 15 cycles of trametinib, there's been a fairly significant amount of reduction, and overall this equates to a minor response. I think important, I wanted to highlight this additional study done by the group in the United States, led by Lindsay Kilburn from from Children's National in Washington D.C. And they're using a medication here. It's a type 2 RAF inhibitor called tovorafenib, and this is a second generation. And so they were using this on patients who had progressed, and a large number of these patients actually had targeted therapy prior and progressed on that. And what they found is that 84% of these patients on the study were BRAF fusion, and 16% had the BRAF V600E. The overall response, RAPNO, was 51%, and the duration response was about 13 to 14 months, with a time to response of about 5 months. So fairly rapid. You can see here, this is the best response. And you can see the orange is those that never had MEK inhibition. The green is the ones that have had MEK inhibition before. So pretty interesting. We don't see a big difference in response to those that had previous exposure to BRAF or MEK inhibitors, and overall fairly good responses for these heavily pretreated patients. Overall, this was fairly well tolerated. I didn't go into too much of the side effects in the selumetinib and the trametinib or the tovorafenib, but overall, we do see a lot of skin toxicities. Rashes are very common. You can see here for tovorafenib, 8% for grade 3. And we do see elevated CPK. Anemia can occur, but most patients, actually, their cytopenias are pretty mild. Paronychia is another issue that we commonly run into with the MEK inhibitors. So that's the nail bed infections or irritation. And this is due to the mechanism of the drug causing, inhibitory effects on the on epidermal formation. Okay, so now switching gears a little bit to specifically the BRAF V600E. This is a manuscript published in the New England Journal by Dr. Eric Buffet and his team. Very exciting work. They had a 2-to-1 randomization of patients that were treated with a combination of dabrafenib and trametinib versus carboplatin and vincristine. And if you remember the curves that we showed before, that were pretty stagnant. Carboplatin vincristine is a well-accepted standard in the United States. And so they did a 2-to-1 randomization. For every 2 kids that got dabrafenib and trametinib, 1 got chemotherapy. Overall, things were pretty well evenly distributed. And what we see here is overall, the responses were pretty dramatic sort of throughout. And we can even see a few responses for patients on the dabrafenib trametinib. Um, and similarly, quite a few responses in the chemotherapy, although not as much. This is overall what happened is that the yellow line showing the dabrafenib and trametinib, uh, their progression-free survival was better than those that were receiving chemotherapy. And therefore, really, dabrafenib and trametinib for patients with BRAF V600E tumors is really now the gold standard therapy. And then this is just the patient-reported outcomes of that New England Journal manuscript. So they use PROMIS. Obviously, we care a lot about not just about how well a tumor is shrinking, we care more about how well the patient is doing, if anything. And usually that does correlate with how much the tumor is shrinking. And here we can see that those that had dabrafenib trametinib, quality of life actually started to increase over time compared to chemotherapy. When they're on the treatment, it's actually worse than baseline. So this was not powered to show clinical significance, but I think it's important to just show that on dabrafenib trametinib, they actually see some increase, whereas in chemotherapy, it does go down. As far as for the side effects for dabrafenib trametinib versus chemo, overall things are pretty similar. We do see more fever with dabrafenib trametinib, more headache, but overall, compared to chemotherapy, we're seeing less nausea, anemia, like cytopenia, less liver toxicity, less constipation, etc. So, be dramatic as far as safety is concerned. So this is just an example of a 3-month-old girl who presented with diencephalic syndrome and nystagmus. And this was published, I think, in the La Saletta manuscript. Um, so this patient had quick clinical deterioration despite chemotherapy with vinblastine, and the biopsy showed BRAF V600E positive. They were started on a BRAF inhibitor. The patient was critically ill in the ICU. And what they noticed is that there was dramatic improvement of the diencephalic syndrome, and the patient's vision normalized. And this is the tumor here after vinblastine. You can see it was growing. And this is the tumor after 10 months on dabrafenib, dramatically smaller. And you can also notice that the enhancement is essentially gone, which is something that we see with these inhibitors, is that the actual imaging characteristics do change. So the role of the neurosurgeon and the neuro-oncologist in this genomic era is that, pediatric low-grade glioma should really be biopsied, because if they have a BRAF V600E tumor or mutation, then these should be managed differently. They would get combination targeted therapy. And in some cases, because a lot of these tumors are hemispheric, if they're not initially resectable or completely resectable, they may become so. And in those cases, a second surgery should be considered because it might be curative. This is a study by Hargrave and Eric Buffet's group again, and they used dabrafenib and trametinib for the refractory relapsed V600E high-grade gliomas. And you can see here, a lot of these patients had very dramatic responses, although they did progress. And so you can see here that the median progression-free survival overall was about 22 months. So if you have a high-grade glioma, these patients are, biologically different than low-grade gliomas. Some of these probably have the CDKN2A mutation or P53, and that can drive resistance in some patients. But you can see some patients were having continued responses, even 2+ years later. So I'm just going to touch on future directions in care. So this is a patient that has a brainstem glioma. and um, it was not easily biopsied, as you can imagine. The patient is 2 years old, 6 months of abnormal gait. Um, some may even be concerned that this would be, diffuse midline glioma with a H3K27M. They were not able to diagnose. They sent this off to Cynthia Hawking's lab in Toronto, and were able to do um, a liquid biopsy with cell-free DNA using droplet PCR, and they were able to detect the BRAF V600E mutation for this patient on dabrafenib, and you can see the dramatic response to this brainstem glioma. We've actually been able to do this ourselves with other tumors, specifically with NTRK fusions with larotrectinib. So every once in a while, you'll get a brainstem tumor that is not exactly what you think it might be. And certainly this with this level of enhancement is unusual. Um, for the BRAF fusion patients, uh, we have a children's oncology group study, ACNS 1833, and this is a non-inferiority study where they're randomizing 2-to-1 salumetinib versus carboplatin vincristine. So just like the study looking in the New England Journal of Medicine paper where they're looking at um, V600E patients, dabrafenib and trametinib combo versus carboplatin. This one is looking at the fusions or patients without the BRAF V600E and without NF1, and they're looking to see is salumetinib as good as chemo, and what is the winner? And they're looking closely at quality of life for these patients to see if there's one that's superior to the other in quality of life or in response for these tumors. So this study is accruing. It's not as fast as we would like, but it's coming along, and they're pretty optimistic they'll get to their expected number. And I think they're going for 180 or so. So they're well over halfway there. Um, last page or slide I'm going to show is, I believe this is one. Yeah, is a study that we worked on at the Canadian group. And ultimately, the trouble is with these tumors is when to stop targeted therapy. With chemotherapy, we've had very, black and white. This is the protocol. When you're done, you just follow, and if they progress, you put them on more treatment. And so what we did was specifically for the BRAF V600E mutant tumors is that there's a lot of concern when you take these patients off of drug, off of dabrafenib, off of trametinib, that they will rapidly progress. And especially if it's in a sensitive area, these tumors, especially the brainstem or along the optic tracts, they can progress and then they can cause obstruction or they can cause significant neurologic impairment. And so what we discussed is that in some cases, you'll be able to, so we suggest treatment up to 36 months for the low-grade gliomas and 60 months for the high-grade gliomas. And if there's ongoing response at that time, then you could consider a taper for these patients, especially the ones to consider. Most for ones with minimal disease, limited expected neurologic deterioration if they progress. And what we do is we were decreasing the MEK inhibitor by 25% every 3 months and the BRAF inhibitor by 25% every 6 months. And so an example of that would look something like this. I would say that right now we're collecting data on our weaning protocol, and this is going to be done by the group at Saint Justine in Montreal as a Canadian cohort. And so there's other groups, throughout the world that are interested in this. I think families are interested in not being on the medication forever. And what we've seen is that certainly patients can, many patients can tolerate a lower dose of these medicines, potentially with less side effects. And so if there was progression, then obviously they'd have to go back on their previous dose. And that's all in this manuscript here. It is just a guideline. This is not, our anecdotal data is pretty good, but I don't think we have a lot of patients off of the drug. again, what we were seeing is when patients were taken off, they were having rebound growth. So we're coming off slowly to see if that can avoid some of that. And we've generally done our MRIs about 1 month before the wean of the next drug, and we just wean one drug at a time generally at our institution. Um, so with that, I'd like to thank everybody for joining, and I can take any questions that you guys might have about BRAF tumors. Thank you.
Yeah, thank you so much, Dr. Craig. That was indeed very informative and too much of info for us because just one point coming from a low middle income country, obviously, BRAF inhibitor are very fancy for us. They are very promising for us, but the cost is a big, big issue. And that's why we know theoretically that the combination always serves better so that you don't cause a rebound MEC stimulation. But combination is like adding on to the drug and not even getting the benefit of a single drug. So we're always thinking amongst what to do. So I know, but really the work, your work, especially the Canadian consensus and everything, have been really informative. So thank you so much for providing us the consensus, and thank you so much for this informative and beautiful lecture. So I'll ping you with few questions, and really, I really appreciate the sentence where you said that how much tumor is shrinking, that is not your answer. How the patient is responding, that is your answer. So I know in low grade gliomas, in high grade gliomas, and in brain tumors, that is actually where we look to. That before the 3 month MRI, I know those figures are important for us, but how much your patient clinically is responding is the first answer you get, whether the response is coming or not. So definitely, that's a learning lesson to all of you. I have few questions for you, doctor. If you're ready, I can just ping them there.
Yeah, absolutely. Go ahead.
Yeah. So, what is your experience of using BRAF inhibitor in metastatic low-grade gliomas?
Um, we've only used it in a couple patients. I think historically, you don't see these patients that often, but they are more likely to progress, and we've had good experience with some shrinkage. In our case, some of the patients that I'm thinking of are, patients that are not the widely leptomeningeal. I have not seen how those patients respond, but patients who have just, a couple metastatic spots, generally they stabilize or will have some response. So we've had good, and you take them off and then they can progress again. So we've had to put them on again. So, and I think that's another point too, is you can retreat these patients. And people have been doing it, I think, pretty frequently for quite a while now.
Metastatic. In fact, the yeah, stopping the drug, when to stop the drug, that's always a question. But you very well highlighted that point in the lecture. I mean, the magic figures of 36 months are always there, but we don't know if after 36 months we taper, and it start progressing. So that
Yeah,
is
for
always
the
a
for the
problem.
patients with the BRAF fusion, we'll probably just do 2 years. But for the V600E, we'll often treat a little bit longer. I think we just worry about those patients a little bit more. So we're trying to collect data on those kids. And I hear you about the cost. I don't know. Do you guys standardly use MEK inhibitors for patients that have progressed? Or for BRAF V600E mutations, are you guys using dabrafenib and trametinib for those patients?
So we are actually using dabrafenib and trametinib.
Okay.
So we have a couple of patients on that, but obviously cost.
Yeah, it's quite a bit of cost. Absolutely. Hopefully, with time, there'll be more competition, and we'll be able to get the prices down.
Yeah, surely. Which is the youngest kid or the lowest age cutoff you have actually used to add a BRAF inhibitor, or do you actually follow any age cutoffs for that matter? Because I understand the
I
dosing are
think,
weight based, and they're. I'm sorry. Yes,
yeah.
please. Go.
So the BRAF V600E for the BRAF fusion for the BRAF inhibitors, I think they're approved down to the age of 1 year old. Um, That said, I have not come across a patient that's younger with a BRAF V600E mutation. I'm sure they exist. Um, I would still use it potentially as compassionate use. For the BRAF, for the inhibitors, we've used, as long as it's a liquid, we've used it down to like just a couple months of life, especially for our patients with NF1. So that have like a big plexiform, maybe on the eyeball or something like that. We've used a very young age. So, but I think those are, you'd have to get special access because I think those are generally approved down to the age of 2. So you'd have to just write the company, but I would probably still use it for a life-threatening tumor.
Human. And
Yeah.
if let's say the cost is no bar, then for a BRAF, your first go to will be a combination or a single agent.
For the V600E,
Yes, yes, yes.
yeah, we've used combination, but I do hear you that if cost was an issue, which in Canada, due to just the way they've set up the system here, it's both. And actually, what happens is the hospital, the national system will cover the dual agents, but if you want to just get one agent, then they make you pay for it, which is very different than maybe how India is. And so if you're going to be able to save by putting them just on one medicine, I'd probably start with the dabrafenib only.
Exactly.
Yeah.
And having said that, in high grade gliomas, when we talk about BRAFs, do you actually believe in doing a concurrent RT BRAF like we do for temozolomide, let's say?
Say it
Or
again.
let's say in high grade glioma, Dr. Craig, we always talk about a concurrent chemo RT, let's say with temozolomide. So
Mm.
the BRAF inhibitor in a used in high grade glioma, do you do it like a concurrent basis, or you complete the radiation and then you believe in adding a BRAF inhibitor?
It's a good question. We've been doing it concurrently. Yeah, we haven't seen any problems with it.
Not even exaggerated skin toxicities or in the radiation field or nothing like that.
No.
Okay. Okay,
Yeah.
which brings me to the next question actually. In high grade gliomas, do the combinations work better than a single drug, especially in high grade?
Yeah, I would say so. That's what the literature's been showing is that
Just
they'll start in many cases you'll see people start with the dabrafenib and then they become resistant and they add the trametinib in. Um, we've just been adding them both in. Um, you know, some of the high grade gliomas, like the standard would be for a BRAF V600E high grade to use to use upfront radiation therapy. I think it's debatable, because you can potentially get the tumor to shrink with the inhibitors first, and then you can use radiation at relapse or at progression. And at that time, I think it's a call if you want to continue the dabrafenib and trametinib if there's been some amount of progression, but it hasn't been, dramatic. Um, just because when you take them off the inhibitors, they can
progress.
they can progress really rapidly, right? So it's a different mentality than I think, oh, they failed this. There's probably still some benefit to the medicine.
Yeah, and I know you have highlighted this point of skin toxicity, but how problematic do you think it is? Like a dose limiting side effect that you feel that you have to stop like drug because of it, or it's like quite
Generally, you can,
bearable in
yeah.
your experience?
Well, so generally, you can treat through the skin toxicity, and you can just treat the rashes with topical treatments. But in some cases, you'll need to just temporarily hold it. We have not had to do that for the V600Es tumors, but for some of the MEK inhibitors, we've certainly had to hold drug for up to a month, mostly for paronychia, but rarely for very significant rashes. So it is something to be aware about. And there's no specific time when it can happen. It can happen 6 months, a year later. Yeah.
Yeah, I do understand that's a problem. And you've been highlighting that you feel cytopenias is not that big a problem.
No, like for our patients, if they're on an oral MEK inhibitor, we don't put a port in generally, and we don't bring them in for fever neutropenia um, if they have a fever. Unless if they're unwell, then we'll obviously see them. But I think, and we've actually been giving vaccinations throughout um, the medications. Is there anything else?
Just the last question. Have you used BRAF inhibitor in infantile high-grade gliomas as a bridge to radiotherapy?
So I haven't, but I know
Am
people
I
that
audible? I'm
have,
sorry for the
and
technical glitch.
yeah, no, you're audible. It's certainly so infantile high grade
Okay,
glioma. I
audible now.
think that would be, exactly one of the reasons to use it. I think if you're having good benefit, because a lot of these high grade gliomas may be a single mutation driver, and if you get a good control with just that medicine, who knows how long you'll be able to push out radiation therapy, maybe indefinitely. So I would absolutely, especially in a young child. And the other thing too is, um, some of these tumors can shrink so much that they can then be resectable as well, and then that can avoid radiation therapy.
All right. That's edge as well. Yeah. That's it with the questions.
Thank you.
Thank you so much once again for this amazing lecture and being so responsive to all the questions. And thank you so much, all the listeners. We are really open to any discussions and any mails, any questions. And thank you so much for pouring so many inputs regarding these webinar series. And once again, this may please enlighten yourself about brain tumor, educate people about the better success rates, and that's where I end this session. Thank you so much, Dr. Craig, once again. Thank you so much for
Thank you.
have a good day.